So let's start. Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Students' Scientific Society of Medical University of Silesia in Katowice, I would like to thank you all and for coming and taking part in International Medical Congress of Silesia 2025. My name is Wiktoria Śliwka, and it is my pleasure to coordinate Neonatology and Pediatrics session. I would like to welcome the esteemed jury, President of the jury, Dr. Marianna Łoskot, and members of the jury, Dr. Hanna Kulik, and Dr. Magdalena Mucha and Dr. Katarzyna Ciepły. They are with us online. We would like to explain the rules of the session. The order of the presentation will be the same as in the abstract book. The maximal time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on the conclusion and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not access the work. In that case, please cross out the number on your card. Other members of the same clinic are able to access the presentation. I would like to remind that according to the regulations, each work must be presented in English. The discussion also should be run in English. If the Commission will ask the question in Polish, the authors of the work are obligated to answer in English. We kindly ask the jury to assess scientific value, way of presenting, discussion, and own contribution. When the session ends, we kindly ask you to give the cards back to the coordinator. Okay, to begin, I think we can start with the first presentation. Katerina Duka, she is with us online. She presents a paper about prescribing habits and of the antibacterial therapy for pediatric upper respiratory tract infectors in primary care. And you need to show us your presentation, okay, on your own.
Can you see my presentation?
Yes, you can start.
Okay. Hello, dear committee, dear auditory. My name is Katerina Duka. I'm the 6th-year medicine student of Riga Students University, and today I'm going to talk about my scientific research. That's full work title is Antibacterial Therapy Used in Pediatric Upper Respiratory Tract Infections, a study of prescribing habits at Children's Clinical University Hospital, Primary Care Department, Latvia. My scientific tutor is PhD Jana Pavāre. So let's begin. The respiratory tract infections are often viral, and they are one of the most common diseases affecting children and are the primary reason for many pediatric visits, including the emergency room. In nowadays, the prescription of antibacterial therapy for pediatric patients with upper respiratory tract infections remains prevalent, and as we know, it's a potential risk for the development of antibacterial resistance in the future. So nowadays, there are many diagnostic tests that offer the potential for delivering quick and precise results, including helping benefit of viral and bacterial infection differentiation. As we know, the clinical manifestation of the respiratory tract infections are often non-specific. So the aim of the study was to understand and analyze the habits of prescribing antibacterial therapy for children with acute upper respiratory tract infections who sought medical help in Children's Clinical University Hospital of Latvia at Emergency Room Primary Care Department. The study was descriptive, retrospective, and it involved 746 pediatric patients, but we analyzed 552 pediatric patients diagnosed with upper respiratory tract infections. The inclusion criteria was all patients aged 1 month to 18 years with possible signs of infection diseases who are consulted in emergency room at primary care department and the data included 2023 November and 2024 November and December. So the results. The most often localization of infection in the study was upper respiratory tract infections, and we can see that the most common diagnosis was common cold in 51.9%, and the second one and third one was the tonsillitis and acute otitis media in 80% of patients with upper respiratory tract infections. 43.3 patients with upper respiratory tract infections received antibiotic treatment, while most of the patients were without antibiotic treatment. Overall, antibacterial therapy was prescribed on the median third day of illnesses, and it is statistically significant result. 49.3 patients with upper respiratory tract infections underwent diagnostic testing, and from them 37.5% of patients received antibiotic treatment, while the patients who didn't undergo diagnostic testing received antibiotic treatment more often. So the streptococcus test was the most prescribed diagnostic test in patients with upper respiratory tract infections. The second one was the COVID and influenza AB test. A C-reactive protein test is one of the newest tests in a primary care department in Latvia, and it was performed in 80.1% of cases with upper respiratory tract infections. And as you can see, the most frequent result was below 20.0 C-reactive protein level milligrams per liter. And we analyzed in which cases the antibacterial therapy was prescribed at what levels, and the median C-reactive protein level with antibacterial therapy was 38.7 milligrams per liter, but without antibiotic treatment it was 88.40 milligrams per liter. So the most prescribed antibiotics for children with upper respiratory tract infections were from the penicillin group, and it was in 31.0% of patients. And in the penicillin group we had amoxicillin and penicillin, and the second most prescribed antibiotics were from the cephalosporin group. It was cefuroxime and cefdroxil. So the conclusions. The prescription of antibacterial therapy in cases of upper respiratory tract infections in this study remains high. It was prescribed in 43.3%. The most prescribed antibiotics for upper respiratory tract infections were from the penicillin group. In this study, the initiation of antibacterial therapy is significantly associated with the patient's day of illness. More frequent use of diagnostic tests, including the C-reactive protein point-of-care test, should be performed before prescribing antibiotics. My references, and thank you for your attention. I'm ready to answer to your questions.
Okay, thank you for your presentation. Now it's time to discuss. Maybe our committee have any questions?
You told us that the antibiotics were prescribed on the third day of symptoms. Was it the day of admission, or was it the second admission because there was no improvement in the child's condition?
It was the day of the patient arrived in the emergency room. It was like the third day of its illness. So the patients arrive at the emergency room, they have this already, they have the illness, and the inclusion criteria was that the patient didn't have the second consultation at the primary care department. So yes, it was the day of admission and day of the illness.
Thank you for your presentation. It was very interesting for me because I working as a primary care doctor with children, and I have a question. Like, I understand this is a retrospective study, yes? Then you should add it to your presentation. That's one. Second question. You are on which year? On 5th year, 6th year?
Sixth year.
6th year, okay. So tell me, what would you do if children came to you with like upper respiratory infection? That's mean the cough, like sore throat, etc. What would you do? You as a doctor.
I would check what are the symptoms, and if the patient has sore throat, I would do the streptococcus test. If it's just a common cold, I would suggest that with symptomatic therapy or perform the C-reactive protein point-of-care test to look if there is an indication for antibacterial therapy. If the patient is really, the symptoms are really slightly more to bacterial infection clinic.
Good, very good. Like in Poland, I guess I do it. I check the combo. We have combo test, yeah, with influenza, RSV virus, and COVID, of course, with cough. I tell you this because you on one of the slides you show us that like 25% children with upper respiratory infection have X-ray, and I don't understand it because it's useful to me. Like, if you know what I mean.
Yeah, the X-ray was performed in the upper respiratory tract infection patients. I guess the doctor slightly thought maybe it could be a pneumonia, so they just checked the X-ray, and there was the upper respiratory tract infection diagnosed.
Okay. Now I see it. Thank you. Like, it's very interesting presentation. Congratulations once more.
Thank you.
Thank you for your presentation. Good job. And now it's time to second presentation. Sleep quality and disturbance in individuals with type 1 diabetes and their caregivers. Presented by Anna Nowak.
Good morning, ladies and gentlemen. My name is Anna Nowak, and today I have a pleasure of presenting a study entitled Sleep Quality and Disturbances in Individuals with Type 1 Diabetes and Their Caregivers, conducted at the Department of Children Diabetology and Lifestyle Medicine at the Medical University of Silesia. To begin, let me review some fundamental facts about type 1 diabetes. It is a chronic autoimmune disease in which pancreas' ability to produce insulin is decreased, leading to impaired blood glucose regulation. It is usually diagnosed in childhood or adolescence, but it can occur at any age. It wasn't until 2017 that the American Diabetes Association include sleep pattern assessment in their standards of medical care in diabetes. That reflects the growing body of evidence linking sleep quality with glycemic control in patients with type 1 diabetes. Sleep disturbances such as daytime sleepiness, nighttime awakenings, irregular sleep schedule, or difficulty falling asleep can all contribute in negative to psychological, physiological, and behavioral outcomes. Even just the fear of night hypoglycemia can have really important role. All these factors make sleep a crucial consideration in a comprehensive care of patients with type 1 diabetes. The aim of our study was to explore sleep-related challenges in people living with type 1 diabetes and their caregivers. Using Google Forms, we designed a survey designed into 3 sections. First section focused on a general demographic and clinical question. Second section assumed sleep quality overall using Aten insomnia scale. The second section evaluated, the first section evaluated current well-being of patient by using a Chica scale. We also distribute our survey by using social media and poster with a QR code. Among the 161 respondents, 90 of them were individuals with type 1 diabetes and 71 were caregivers. Average age of children of the caregivers was 10.8, with the age range from 3 to 18, and average weight 40 kilos. Focusing on individuals with type 1 diabetes, average age was 28.8, with age range from 11 to 55, and average weight 70.2 kilos. So let's move on to the main part of our results, sleep quality. 66% of caregivers and 57% of individuals with type 1 diabetes reported difficulty falling asleep. 86% of caregivers and 67% of individuals experience insufficient amount of sleep. And finally, 93% of caregivers and 77% of individuals with type 1 diabetes consider their sleep quality as unsatisfactory. This amounts 134 out of 161 respondents. Okay, but have you noticed the discrepancy in the second column? Only 40% of individuals with type 1 diabetes and as much as 83% of caregivers experience frequent or very frequent nocturnal awakenings or complete insomnia. So let's focus on the caregivers and see what's happened with this disproportion. 69 out of 71 caregivers use a phone app to monitor their child glucose level. 88% of them reported fear of nocturnal hypoglycemia, and 90% of them reported a decline in sleep quality. It leads us to hypothesize that the fear of hypoglycemia was a crucial factor contributing a disproportion in the area table. In conclusion, sleep quality in both individuals with type 1 diabetes and the caregivers were significantly reduced. And we should pay more attention to a proper sleep in our patient and in their family. So I believe that after today, Wish for Sweet Dreams will never be the same. Thank you so much for your attention, and I open to any question.
Congratulations of your work to your tutor also. I really like the end of your presentation. This was a good joke. I like it. Like this is example for you. Okay, so the question I would like to ask you: contribution for your work.
Okay, so first we write to a biotic commit for approved. After that, we design our survey and we join to a group on Facebook for people with diabetes, and there we share link to our survey. Also, we contact one of the influencers on Instagram that that have account about diabetes, and he also share our link with his followers. And we also make a poster with QR code, and this poster was on the ward in our hospital. And before that, to know more about the topic, we write a review about it.
Oh, that's a lot of work, so congratulations to you for that. Thank you.
Thank you so much.
I also agree you have a nice way of talking. The tempo and your English is quite nice.
Thank you so much.
You can be proud of yourself. I wanted to ask you the questions on this Google form, were they all written by someone of you, or you used something prepared by someone else?
We used to scale, Athens Insomnia scale and Chica scale, and other question was us.
Okay, thank you.
So thank you so much.
Okay, thank you for your presentation. I would like to ask to present the paper Tracking Type 1 Diabetes in Children in Science from Lublin, Vivo the Ship by Zuzanna Pudzianowska.
So, dear guests, dear scientific committee, my name is Zuzanna Pudzianowska, and I am third-year biomedicine student from Medical University of Lublin, and I am honored to be here today and present you our work entitled Tracking Type 1 Diabetes in Children, some insights from Lublin Voivodeship. So, to begin with, okay, it's fine now. So to begin with here, just a quick reminder about diabetes. So as a former speaker said, type 1 diabetes is a most common chronic disease diagnosed in a pediatric population. Its pathogenesis is associated with an autoimmune process leading to destruction of pancreatic beta cells, ultimately resulting in complete loss of insulin production. And as a consequence, a lifelong exogenous supplementation is required to the disease to be managed. Whereas type 2 diabetes is commonly occurring among adults and is usually caused by a combination of insulin resistance and insulin deficiency, both as a result of obesity. But as you can tell from the title of this presentation, I will be mainly focusing on type 1. So why did we choose to dig into that particular topic further? Because as you can see, here are some alarming statistics, because according to 2024 report, about 9 million people worldwide suffers from diabetes type 1, and among them, nearly 2 million are children and adolescents. And what is even more alarming is that 30,000 people under 25 years old die from undiagnosed diabetes. And this is why a further research regarding some potential risk factors is needed, because it may lead to better and quicker diagnosis. So our research aimed to analyze some trends and insights in the incidence of diabetes type 1 in the pediatric population, and additionally it aimed to assess some relationship between the occurrence of the disease and selected factors such as sex, place of residence, and previous infections. When it comes to methodology, a retrospective analysis was conducted on total of 544 patients aged from 0 to 18 years old, hospitalized at the Medical University University Hospital Children's in Lublin, diagnosed with diabetes type 1 between 2019 and 2024, based on the presence of beta cell autoantibodies against insulin, glutamic acid decarboxylase, cytoplasmic proteins in beta cell, and protein tyrosine phosphatase. And we use MedCalc software to perform some statistical analysis. So moving on to the results. So first of all, factors such as sex and place of residence turned out to be correlated with the incidence of diabetes type 1. Significantly more diabetic patients were male and came from cities or towns. And this might be correlated or associated with hygiene hypothesis and its influence on the onset of autoimmune diseases. We also tested seasonality impact, since it is known that autoimmune diseases onset is commonly triggered by infections. So we might expect that more hospital admissions will be in autumn and winter. But interestingly, this correlation turned out to be insignificant. Nevertheless, other infections, and especially COVID-19 pandemic, had a huge impact on diabetes type 1 onset. As you can see from this figure here, a lot more cases of diabetes were diagnosed during or after the pandemic rather than before. Moreover, parameters like glycemia and ketoacidosis were higher and occurring more commonly during and after the pandemic again. Also, diabetes type 1 was diagnosed more frequently with patients with a higher body mass. And COVID-19 had also impact here because, as you can see, median of total cholesterol and median of triglycerides were significantly higher during or after the pandemic rather than before. We also checked HDL levels, and it turned out to be slightly lower during or after the pandemic, but unfortunately this score was near significance. So, to summarize, diabetes type 1 is definitely a multifactorial disease with genetic predispositions as probably the most important cause. However, sex, age, body mass, place of residence, and previous infections, especially COVID-19, have an impact not only on the onset of the disease, but also on its course. And we can say that they can be considered as a potential new risk factors of the disease. So that will be all from me. Thank you so much for your attention, and I will be more than happy to answer any of your questions. Thank you so much.
Nice presentation, thank you very much. I have two questions for you. First one, you have over 500 patients. Did you collect the data by yourself, or was it some IT person who helped you build the database?
No, it's all thanks to, can we see the presentation again? No, okay, that's fine. It's all thanks to my supervisor of our work, medical doctor Izabela Rysz. She collected all this data through all these years I think by herself. And thanks to her work, we were able to do this presentation. And she was there in the supervisor of our work.
Did you do the statistics?
Personally, no, but one of our co-authors did because he's, very
experienced
good, in this field. Yeah, exactly.
And the second question: do you think that the COVID itself was the cause of this higher rate of diabetes, or everything that was happening around, such as I don't know? Some difficulties to go to the doctor because, there were some problems to get the appointment?
That's a really interesting question. Thank you for it. Because, for example, as I said before, the diabetes type 1 was correlated with higher body mass and higher levels of lipidograms. And this might be because of the pandemic thing by itself, related to, you know, staying at home and getting difficult to get to the hospital early enough. But what is interesting is that I read an article from Nature, I think, from 3 years ago, that they said that COVID itself may have an impact on higher glycemia levels, but you know, this isn't properly established yet, but it might have a correlation with this.
That's all for us.
Okay, thank you so much.
Thank you.
Thank you. And now it's time for a third presentation, analysis of function, profile, mobility, and quality of life in children with arthrogryposis, presented by Barbara Kowalska.
Good morning, ladies and gentlemen. On behalf of the Students' Physiotherapy Research Club in Pediatrics, I would like to present you the results of our study titled Analysis of the Functioning Profile, Mobility and Quality of Life in Children with Arthrogryposis. Arthrogryposis is a rare congenital disorder characterized by joint contractures affecting 2 or more areas of the body. It significantly impacts children's mobility and daily functioning. The objective of this study was to analyze the functional status of children with arthrogryposis, with particular attention to their motor limitations. A key focus was placed on assessing their quality of life and understanding their daily challenges and capabilities. To achieve this, we used well-established and widely recognized assessment tools, such as the Pediatric Outcomes Data Collection Instrument and Functional Mobility Scale. Here you can see several photos of our patients with this condition, and you can imagine the kinds of deficit it may cause from the very first day of their lives and also later on. Okay, Pediatric Outcome Data Collection Instrument measures various domains of health, such as global functioning, mobility, physical functioning in sports, pain and comfort, and happiness. And it is commonly used to evaluate the quality of life in children with musculoskeletal disorders. And results are presented separately for each of the subscale, and it is converted into a score ranging from 0 to 100 points, where 0 points indicate the worst possible level of functioning, and 100 points indicate full optimal functioning. To evaluate mobility specifically, we used FMS, Functional Mobility Scale. It is a scale which classifies child's level of walking ability over 3 distances, 5 meters, 50 meters, and 500 meters. And it ranges from 1, meaning the child uses a wheelchair, to 6, meaning independent walking and on all surfaces, including stairs. Okay, so study groups and characteristics. The data used in this study were collected from patients treated at Arthrogryposis Treatment Center at University Children's Hospital in Krakow. The study included 76 children diagnosed with arthrogryposis, aged between 2.5 and 19 years. Among them, 52 children had amyoplasia, so the most common form of arthrogryposis, which gives us 68.5%. Amyoplasia is present at birth and it typically affects all 4 limbs symmetrically, with joint stiffness and muscle weakness resulting from decreased fetal movement during pregnancy. Remaining 24 children had other types, so it gives 31.6%. When assessing functional mobility, we found that the scores were distributed mainly at the extremes. Specifically, 34.2 scored 5, meaning they could walk independently on flat surfaces but needed help on stairs. 39.5% scored 6, achieving full independent mobility, including managing stairs, but 18.4% of the children scored 1, indicating no independent ambulation. In the quality of life domains measured by pediatric outcome data collection instrument, the mean values were as follows. Mobility 60.8 points, upper extremity function 60.58 points, sports and physical functioning almost 45 points, indicating the most significant difficulties, pain and comfort 75.9 points, suggesting relatively good pain control. Happiness 64.2 points, showing moderately positive emotional well-being, and global functioning 60.6 points. So, in conclusion, we can say that children with arthrogryposis show a very wide range of functional abilities, while significant proportion is fully mobile. A notable group requires wheelchairs or assistance. So their quality of life scores indicate that despite physical challenges, many children maintain good comfort levels and positive outlook in life. However, the physical functioning, particularly in sports, remain a major area requiring support. Moreover, the FMS is a sensitive tool for differentiating levels of mobility and can serve as a key element in evaluating therapeutic needs and planning rehabilitation in children with arthrogryposis. Thank you very much for your attention. I will be happy to answer your question.
Okay, congratulations for your work. I have a question. The one question is, you said that 60% of these children, and it's a really large group, so congratulations. Mobility was good, yes?
It was the points which the children got from the pediatric outcome data collection.
Okay.
It's like mean measure. It was mean measure.
Mean measure. So I understand that 60% of these children are walking by themselves or with the support of orthopedic devices?
Yes, it was. Yes, it was like in a pediatric outcome data collection. You score. The score range is from 0 to 100 points, and it was mean points in this obstacle of mobility.
Okay, but what does it mean?
0 points is like indicates the worst possible level of mobility, and 100 points indicate optimal functioning.
Okay,
like
so you don't know how they are, how they were moving. Yes, you know only what they feel about moving. Yes.
Yes.
This is okay.
Yes.
Okay. Thank you.
You evaluated 76 children. Over what period of time? When they were admitted to the hospital?
It was about a year, because we continue, or even more, like 1.5 years, because we collected some of this information also for our work in the last year. So it lasts a bit more than 1 year.
So that's along how you were collecting the data, or when the children were in the hospital?
Like
they were on from 1 year? All the children were in the hospital within 1 year?
Yeah, yes.
Okay, that's a lot of children with this disease.
Yes, because it's the place where in the Krakow there are a lot of children treated on gryposis. Sorry.
And you used 2 scales.
Yes.
Did you look at the data and calculate it by yourself, or they were written somewhere in the documentation and you just took the numbers?
We took the numbers from FMS were written, but about the pediatric outcome data collection, we collected it for our work in the previous year. So we collected them just previous year, and it's the continuation of our work, I would say, because the last year we did work about evaluating the pediatric outcome data collection and how to use it with arthrogryposis, and we tried to say that it's very good instrument to use in this context. So,
thank you very much.
Thank you.
Okay, and now it's time for presentation about tracking the tumor trail, ultrasound and histopathology of triad tumors in pediatric patients. Martyna Wróblewska, Konrad Katela. Anyone is here?
Okay. Hello.
Oh, you're online.
Yeah, unfortunately.
Okay.
Yeah.
Okay, so please share your presentation, okay?
Of course. 1 second.
And when you are ready, you just start.
Okay. Okay, there's my presentation. 1 second, it's loading. Okay. So, distinguished audience, my name is Martyna Wróblewska from Jagiellonian University Medical College, and I cordially invite you to my presentation titled Tracking the Tumor Trail, Ultrasound and Histopathology of Thyroid Tumors in Pediatric Patients. Okay, so why is this study important? The significance of our study lies in addressing the critical need to differentiate between benign, borderline, and malignant tumors in pediatric patients. Because of that, we decided to analyze histopathological and ultrasound features of thyroid lesions to improve and accelerate the diagnostic process. We conducted a retrospective study on a cohort of 47 diligently selected patients with thyroid nodules who underwent surgical treatment. Each case included high-resolution ultrasound imaging, histopathological, and clinical evaluation. We focused on 3 diagnostic groups based on WHO classification from 2022, which distinguishes benign, borderline, also known as low risk, and malignant neoplasms. The first example of benign tumor is dyshormonogenetic thyroid goiter. And in both of our patients with this tumor, ultrasound revealed an enlarged thyroid with solid hypoechoic nodules. Pathological examination in both cases revealed fibrosis, hemorrhage, and inflammatory granulation tissue. The thyroid architecture was microfollicular with slightly enlarged and infrequently overlapping nuclei, confirming the diagnosis. The second example is the thyroid follicular nodular disease, which is also benign, and ultrasound demonstrated oval iso to hyperechoic nodules with hypoechoic halo. Histological evaluation revealed dilated follicles with flattened to hyperplastic epithelium and compressed non-nodular thyroid tissue. The next example of benign tumor is thyroid follicular adenoma, and in this case, ultrasound showed large, oval to round solid nodules with mixed echogenicity, hypoechoic halos, and intranodular vascularization. Histological evaluation revealed encapsulated nodules with focally thickened, irregular capsules without invasion, crowded follicles, and compressed adjacent follicles reaching colloid. Also enlarged nuclei and clearing and overlap. The last example of benign tumor is oncocytic cell adenoma. In this case, ultrasound showed well-demarcated round to oval hyperechogenetic nodules with small hypoechogenetic foci and increased mixed vascularity. Histology revealed densely packed eosinophilic cells with hypoechogenetic foci corresponding to inflammatory tissue, along with areas of fibrosis and medium-sized vessels. Cells were pleomorphic with enlarged nuclei and prominent nucleoli. Okay, now to the borderline tumors. The first one is non-invasive follicular thyroid neoplasm with papillary-like nuclear features. In this case, ultrasound showed oval to round nodules with regular margins, generally hypoechoic, with posterior acoustic encasement. The capsule appeared as hypoechoic rim unless the nodule was markedly hypoechoic itself. Histology revealed well-defined follicular nodules without capsular or vascular invasion. Now the follicular tumor of uncertain malignant potential, and in our group, all patients had incidentally detected nodules on ultrasound imaging that were appearing as small, round to oval, predominantly well-defined nodules with hypo and hyperechoic areas. Some had poorly defined borders and mixed vascularization, and histopathological evaluation showed round to oval follicular nodules with uncertain capsular invasion. Now the last example of the borderline tumor is well-differentiated tumor of uncertain malignant potential, and ultrasound showed medium-sized, well-defined hypoechoic nodules, sometimes with hyperechoic areas, round to oval, and one case involved a multinodular goiter. Histopathological evaluation revealed predominantly microfollicles with oval, well-defined nodules showing capsular and vascular invasion. Now I would like to talk about malignant tumors, which are differentiated thyroid carcinoma and poorly differentiated thyroid carcinoma. In these cases, ultrasound of PTC showed an irregular hypoechoic nodule with mixed vascularization, while PDTC appeared as large hypoechoic masses. In histopathological evaluation, PTC had follicles with glassy nuclei and capsule penetration, whereas the PDTC exhibited neuroendocrine features with salt and pepper-like nuclei. Okay, so in conclusion, despite diligent ultrasound and histopathological and clinical evaluation, the diagnosis is not sufficient enough for precise differentiation of thyroid nodules, and fine needle biopsy still remains essential. Also, advances in AI may enhance risk of stratification and support conservative management strategies in selected pediatric cases. And also the take-home message is that the most specific feature of malignant thyroid tumors is the presence of Samona bodies on histopathological examination and microcalcifications on ultrasound imaging. Also, I would like to add that an article on which I base my presentation has been released, and I warmly invite you to read it and deepen your knowledge on this topic. It is available through the QR code. And thank you for your attention, and I am happy to take any questions.
Thank you for your presentation. Very nice. I really like the aesthetic of presentation. You take USG and histological picture. That was really good. I have a question for you. Did you do it by yourself, like this histological pictures, and from the USG you take it by yourself?
Okay, so no, unfortunately, I didn't do it by myself. It was taken by our specialists, our work tutors, Professor Dominika Janusz and PhD Monika Kujdowicz. They were responsible for this because they specialize in these cases, but I didn't do it myself.
Okay, so congratulations to your tutors. It's really impressive for me, and congratulations of your article. That's really nice. And the next question is: do you know what is the treatment with this types of tumors in children?
So they underwent surgical treatment because. Usually, the only way to treat it is just the surgical way.
Yes, that's the proper answer, so thank you.
You evaluated 262 patients, but only 47 were included in your study. What was missing from the others? Why did you exclude them?
Okay, that's a very good question. The reason why we excluded them was because the data that was collected throughout the years, because the data was collected from 2010 to 2023, not in every case the data was enough for our work. So main reason that we excluded the patients was because lack of data, and the pictures
which data? What was most commonly missing?
So I think that the images weren't good enough, and they weren't. The resolution wasn't high enough, so that's why we excluded them.
You also said in your conclusions that we can use AI for support in treatment, in diagnosis. Do you have any experience with that?
So I read about it. I didn't yet use it by myself, but I think that it is the future, and that AI may detect things on especially histopathological and ultrasound images that we cannot spot with our eyes. And yeah.
Okay. That was one of your conclusions, and it wasn't mentioned in the presentation, so I wanted to ask more about it. Thank you.
Thank you very much.
Thank you. Yes, of course. And now I want to invite Anna Matusik. She will present the paper Analysis of Basic Physical Activity in Children with Type 1 Diabetes and its Impact on Glycemic Control.
Ladies and gentlemen, my name is Anna Matusik, and today I would like to talk about analysis of basic physical activity with children with type 1 diabetes and its impact on glycemic control with my colleague Zuzanna Mielniczek and Teraz słychać mnie lepiej? So once again, ladies and gentlemen, my name is Anna Matuzik, and today I would like to present you a presentation about analysis of basic physical activity in children with type 1 diabetes and its impact on glycemic control with my colleagues Zuzanna Mielniczek and Marlena Brozowska at the Department of Children Diabetology and Lifestyle Medicine in Katowice under the supervision of Elisa Skała-Zamorowska, PhD, and Professor Przemysława Jarosz-Chobot. First of all, we should admit that physical activity has a significant impact on the management of diabetes, such as enhanced insulin sensitivity, lower glycated hemoglobin, support metabolic balance, reduce adiposity, improve muscle mass and strength, lower risk of premature all-cause, extended remission time in children with the new onset diabetes mellitus, and many more. But there is no advantages from physical activity without proper insulin modifications, adjusting person-centered activity goals, and knowledge of exercise type, such as aerobic and anaerobic, and timing of the exercise, glucose monitoring, such as continuous glucose monitoring or properly using a glucometer, contextualizing risk of hypoglycemia, nutritional strategies, and individual fueling plan during physical activity. The aim of our study was to analyze the level of basic physical activity in children with type 1 diabetes and its impact on glycemic control. And we want to assess the methods used to control glycemia during physical activity and identify one of the main causes of glycemic instability during exercise. And we prepare a preliminary cross-sectional survey based on ISPAD guidelines. Our group consists of 28 patients from the Diabetes Outpatient Children Clinic in Katowice. And our group consists of children at school age. Minimal age was 9 years old, maximal age was 17 years old. They were mostly men. Average onset of disease was 10 years old, and average duration of a disease was 5 years old. And as you can see on the diagram, the dominant type of insulinotherapy was personal insulin pump, and luckily to hear to us that 93% of respondents use continuous glucose monitoring. And according to ISPAD guidelines, the recommended 60 minutes of moderate to vigorous intensity physical activity every day, only 11 respondents knew about it, but lucky to hear to us that all of them participate in physical activity in amount of 3 to 4 hours per week, but only 66% take consideration the type of physical activity. But even that all of them take part in physical activity, 61 of them discontinued physical activity due to hypoglycemia, and these episodes were mainly symptomatic. And something about the guidelines, we should know that insulin modification should be done before and after the physical activity. And it's really important to remember that it should be modification in prandial and also basal insulin, and it depends on the time between the meal and the physical activity. So according to our results, in our study group, about 80% do not modify basal insulin before exercise, and about 30% do not modify parental insulin before physical activity. And as I said before, it's important to remember that after physical activity, prandial and basal insulin should be also modified based on exercise type and glucose levels. As you can see in our study group, close to 80% do not modify parental insulin after physical activity, and 70% do not modify basal insulin after physical activity. And it's really important to remember about preventing hypoglycemia. And when physical activity is done closely to 20, when the severe hypoglycemia is closely to when severe hypoglycemia in the pretending 24 hours is generally a contradiction to exercise. And it's really important to remember that at least 30 minutes physical activity requires therapy management strategies before, during, after, and then overnight the physical activity. And glucose level during activity in exerts a range of 90 to 270 milligrams per deciliter. And in our study group, discontinuation of physical activity classes was when the average glucose value is about 72 milligrams per deciliter. And as you can see on the ISPAD guidelines, that is too late, and the physical activity should be already postponed. And something about the nutritional strategies, ISPAD guidelines are very strict with it, and then even say about what should contain of carbohydrates and other nutritional elements. And as you can see in our study group, 25% do not consume any meal before physical activity. 75% patients participating in physical activity classes consume a meal at varying times, from 5 to even 2 hours before. And as you can see, that 30% only of our patients reported consuming the above mentioned products during physical activity, and providing additional carbohydrates, depending on glucose level, can clinically significantly lower hypoglycemia. And about post-out workout meals, about 36% pay attention to consuming appropriately balanced post-workout meal with the recommended amount of macronutrients, and majority of patients primarily consume carbohydrate meals with low protein content, such as fruit purees, for example. Coming to the results, as I said before, all of our patients participate in physical education classes, but the vast majority do not modify basal and bolus insulin doses prior and after to physical activity. And average glucose level was too high. The physical activity should be already postponed, and the meals consumed before physical activity and the timing of their consumption vary greatly and do not follow a consistent pattern. And conclusions, that our preliminary findings indicate that children with type 1 diabetes mellitus face challenges in maintaining stable glycemia during physical activity, and a major contributing factor is indicate or properly in time insulin modifications. Thank you for your attention. I'm glad to hear some questions.
Okay, congratulations for your work. I have a question from Dr. Ciepły, because she can't speak loudly, so I would read it. Okay, Dr. Ciepły asks: is any type of activity more preferable than others? Do you know about it?
It mainly depends on the pace of the activity and the intensity, because it's moderate to vigorous. Mm-hmm. So not walking, maybe running, but there's no specific type of exercise that is preferable.
Okay. Thank you.
Thank
you. Do you know what to do to prevent hypoglycemia when exercising? Or when you have one, what to do?
To prevent hypoglycemia during physical activity is remember to modify insulin. But if you already have an episode of hypoglycemia, it's really important to not participate in physical activity anymore. And as I said before about carbohydrates, so you can something like dextrose tablets, or if you don't have any it can be something like a sweetened beverage. Thank you very much.
Thank you.
Okay, now please welcome Anna Siodłak. She will present the paper Clostridius diffidens infection in children treated at Gastroenterology Department, retrospective study.
Good morning, ladies and gentlemen. My name is Ania Siodłak, and I'm very pleased to present our work on Clostridium difficile infection in children treated in gastroenterology department in Katowice as a retrospective study. To begin, I would like to briefly discuss the common causes of Clostridium difficile infection. The main contributing factor are comorbidities, especially inflammatory bowel diseases, previous treatments such as antibiotic therapy and PPIs, as well as recent hospitalization. As is shown on the data on the left, this infection affects a large portion of patients hospitalized in Poland. When it comes to the aim of our study, we wanted to analyze the potential risk factors and clinical picture contributing to the development of Clostridium difficile infection in children treated in pediatric gastroenterology ward and outpatient clinic in Katowice as a retrospective study, like I said before. So we analyzed 109 patients between years 2020 to 2024, and the collected data included age, sex, weight, BMI, clinical symptoms at admission, as well as their frequency of reoccurrence. We also had additional clinical and background information shown on the right. One key factor in our study was age. We observed that the patient over 10 years of age had a higher range of Clostridium occurrence and Clostridium relapses, like it's shown here. Yeah. Also, surprisingly, patients who were undernourished rather than those with obesity had been frequently affected by the infection, like you can see here, and the obese one. In terms of neonatal data, children born via vaginal delivery were more likely to have Clostridium difficile infections compared to those delivered via cesarean section. Premature birth under 37 weeks, as well as the low birth rate, weight, did not statistically show any impact due to the small sample size. Notably, current nutritional status, it was not important compared to the, it was more important to the neonatal parameters. Additionally and unexpectedly, patients who were breastfed in our group were more affected by the infection rather than those fed with formula. Okay, the clinical symptoms that our patient presented, the most common were abdominal pain and blood in the stool. Fever, vomiting, and diarrhea were also present and also reported, but less frequently. When it comes to the lab tests, the morphology of our patient were normal, except for hemoglobin level, because frequently this parameter was below normal range. Like you can see on the chart, there was an interpatient variability in those parameters. When it comes to liver enzymes, they were generally within normal limits, although GGT was mildly elevated, and also we see the interpatient variability. We also collected the inflammation markers and C-reactive protein in approximately 60% of our patients have been elevated, and in some of our patients this data were coming nearly 300 milligrams per liter, which is a sign of systemic inflammation. Also, we collected calprotectin level, and the levels were measured in 81 patients, and we observed a very interesting fact that 33 patients had a nearly exceeding level of 2 to 2,000 micrograms per gram, and 28 of them had inflammation bowel disease. And very interesting fact as well, the striking number of 93% of our patients had comorbid conditions, and the most common of them were ulcerative colitis and Leśniewski Crohn's disease, followed by those listed on the left. And we analyzed the potential risk factors, and approximately 60% of our patients had been hospitalized prior to the infection. 80% of our patients had viral infection. Most of them had rotavirus infection, and some of them had co-infection. 44% had been using antibiotics prior to the infection. And 36% of them were taking PPIs, especially omeprazole. When it comes to the treatment, our patients were primarily treated with vancomycin and metronidazole, and 2 of our patients had to undergone the fecal microbiota transplantation. We also had 3 major complications, such as bowel perforation and megacolon toxicum, and they required a surgical intervention. And when it comes to the conclusion, Clostridium Aedes difficile infection in our hospitalized patient is often associated with comorbidities such as inflammation bowel disease, systemic inflammation, and undernutrition. Early recognition and individualized treatment are very crucial, especially in children with inflammatory bowel disease and with those children with pure nutritional status. Thank you for your attention. Yeah, that's all.
You have a very nice way of presenting, and I think you are the first one to use the pointer to show us something on the slides. I wanted to ask you, do you know how fecal transplantation happens? What to do? How it works?
Yes, it's the doctors who do it have a few healthy participants who give their stool, and it's dehydrated and made into tablets. And for children, it's usually applied via gastrointestinal tube. They don't have to eat it.
Thank you for your presentation. Greetings to Docent Więcek.
Yeah.
From me, please. But for a question, I have few questions. One, did all of the group still live? Do you have someone who died?
No, they are all alive, thankfully.
Okay, because you show us that one patient had bowel perforation, and I know this patient. That's why I ask. But it's really serious things for this patient. Okay, that's one question. Second, you mentioned about allergies, yes, with Clostridium difficile. What kinds of allergy?
There are a few patients that had allergies of the milk, for the milk when they were children.
So food allergy, yeah?
Food allergy, but there were a few that had general high allergies. So pollens and flowers and trees.
Like spring allergy, okay.
Yes, spring
and last question, it's premium question. So what we should do as doctors to prevent this infection?
I think it's easy to say for us, but the most important thing is to wash our hands between patients with water and soap. And also it would be good to really consider an antibacterial therapy when treating patients with inflammatory bowel diseases or other risk factors. Because as we see, there were only 7 healthy patients that had Clostridium difficile infection. So we have to focus on those with other comorbidities.
Okay.
Yes, and also implement some isolation for these patients.
Yeah,
so
of course.
Not to cross these pathogens.
Okay, thank you very much.
Thank you very much.
Okay, I would like to ask to present the paper Bacteria and Charge, Diagnosis of Complex Congenital Anomalies Syndromes by Maciej Dzierżak.
Good morning. All right, I'm gonna go through Bacterial and Charge, which are quite, I think, known anomalies syndromes. To start with, both have been described for quite a long time, since second half of 20th century, although we don't have strict guidelines for diagnosis of either of these syndromes. So the aim of this presentation was to go through the current literature, find the articles that would propose some of the diagnostic criteria for both of these entities, and then compare 2 patients from the Department of Medical Genetics at the Krakow with those diagnostic criteria to show if they're easy to use. Just to mention, the traditional criteria for Bacterial and Charge are coming from the names of those entities. For Bacterial, it's vertebral, anorectal, cardiac, tracheoesophageal, renal, and limb anomalies. And for Charge, it's coloboma of eye, heart defects, atresia of choana, retardation of growth and development, genitourinary malformations, and ear abnormalities. To start with Bacterial, the most current criteria come from the work by Van de Putte et al. From 2019. The authors analyzed the EuroCat database, which includes data from most of the European countries, and proposed some criteria based on that database. They found that the anomalies that are in the name of the bacterial are the most important, and to diagnose a bacterial we need 3 major anomalies from them. They also suggested 3 subtypes of bacterial, depending on the importance of the anomalies that are observed and the presence of anomalies not typical for bacterial. The additional criterion that is very important is exclusion of any known genetic disorder that could cause such anomalies. And our first patient was a 4-year-old boy at the first presence at the department. Here he's obviously older. He had multiple congenital anomalies. The most important were right sided cleft lip, the hypoplasia of right auricle, the esophageal atresia with tracheoesophageal fistula, which is the most common for bacterial, as well as the congenital absence of anus. At the time of examination, he was lower and lighter than most of the boys his age. He had also dysmorphic features, as you can see. Some more pictures of him. All right. We did, as I mentioned, some genetic tests to look for some etiology for those anomalies. We did the microarray, which proved normal. We did karyotype, which was also normal. And we did whole exome sequencing, which showed us 2 heterogeneous variants, but neither of them was typical for bacterial. Neither of them could explain his symptoms. In the presence of vertebral anomalies, anorectal malformation, the atresia in his case, and ventricular septal defect, as well as tracheoesophageal fistula, which I mentioned, we could diagnose bacterial. But he had also a laryngeal cleft, which didn't allow us to diagnose strict VACTERL, we had to diagnose VACTERL plus subtype. Okay, when it comes to charge, the criteria are quite older, and with charge there is also a more complicated situation. Such as VACTERL, the charge used to be considered an association, so the syndrome that doesn't have one etiologic cause, one factor that could explain those symptoms. But in 2004 there have been found a gene, CHD7, that is described in approximately 2/3 of the cases of charge. It is not obligatory to find this gene mutation in patients to diagnose charge, but it supports our diagnosis. The current criteria come from the work by Hale from 2016. He's showed some major criteria, one of which is the pathogenic variant of CHD7, but also coloboma, atresia of Hoana, or anomalies of ear. And our patient is a 10-year-old female, which had also many congenital anomalies. She had dysmorphic features, one of which was dysmorphic auricle, so that comes with the anomalies of outer ear. But she also had bilateral coloboma, defects of heart, both ventricular and septal, as well as defects of brain, such as absence of septum pellucidum or agenesis of corpus callosum. She was also much lower than the general population. We did some genetic testing as well. The karyotype again was normal. We did the NGS analysis of CHD7, which proved normal, but that didn't prevent us from diagnosing charge in her. She did have two major anomalies, as I mentioned, coloboma and dysmorphic auricle, and several minor. So without the finding of CHD7 gene mutation, we were still able to diagnose charge in her. To sum up, thanks to those current criteria, we are able to pretty easily diagnose both VACTERL and charge in our patients. And what is important, we should use some criteria for them, because there was a study by Solomon in 2012 that asked the clinical geneticists how do they diagnose VACTERL, and proved that there was no similarities between them. Some geneticists needed more anomalies to diagnose VACTERL, some needed less, and they chose different anomalies as the most important. And that's all from me. I'm ready to answer your questions.
You've chosen very rare diseases. Where you get the idea from?
Well, I'm part of the student scientific group of clinical genetics, and well, actually, it started as a case report on VACTERL, but then I found the fact that there are no guidelines and went into it.
I see. I've only witnessed 2 cases of VACTERL disease, so VACTERL association. And for me, that was very interesting because I'm from pediatric surgery department, and that's something I witnessed myself. And I wanted to ask you whether you witnessed some of the operations. Were you in the operating theater when they have, for example, anar atresia operated?
Unfortunately not.
No. You are from genetic department?
Yes.
Okay.
So I saw the patient with VACTERL, but I didn't see the operation itself. Thank you.
Thank you so much. Now, please, Alexandra Letzner. She will present the paper Clinical and Emotional Aspects of T1D in Females with Multiple Diagnosed Siblings, a Parental View.
Okay, so good morning, everyone. My name is Alexandra Lesnar. I'm from the Department of Children Diabetology and Lifestyle Medicine. And today I will present the topic. The topic of my presentation will be clinical and emotional aspects of type 1 diabetes in families with multiple diagnosed sibling, a parental view. So type 1 diabetes is a chronic autoimmune disease. Sorry, I have to... So type 1 diabetes is a chronic autoimmune disease, which usually begins in youth, so in children and teenagers. And the early symptoms of this disease are really non-specific and sometimes can be, and a lot of time can be overlooked. That's why usually the first symptom that appears in children is diabetic ketoacidosis. The risk of developing the disease before the age of 20 in someone who has an affected sibling is 4% in comparison to 0.4% in a general public. The screening is really important, especially in prevention of type 1 diabetes, because it can help to diagnose the disease in a really early stage, usually before the symptoms of the disease appears. And also it helps to control the disease development and lower the risk of diabetic ketoacidosis. 2 screening programs were available in Poland, Inodia and GPAD, and GPAD is still available today. Our study aimed to compare the clinical data and emotional state of the parents during the first and the second diagnosis. We also wanted to examine if the parents' awareness about the risk of developing the type 1 diabetes in sibling will affect the second child clinical state. Our study included 37 families. The data was collected from medical records. The personal questionnaire, our custom questionnaire, was used to assess the knowledge of parents about their awareness of type 1 diabetes risk in other child, their knowledge about the existence of screening, the level of psychological stress, and implementation of lifestyle changes. As we can see, when we compare the medical data from the first and the second child, we can see that the second child was in a better medical condition at the onset. The blood glucose level, glycated hemoglobin was lower, and the diabetic ketoacidosis appeared less frequently. And also the typical symptoms, the similarity of typical symptoms the typical symptoms appeared in a similar frequency, but slightly less so in the second child. When we compare the circumstances of diagnosis, they also differ. The first children usually were diagnosed due to sudden diabetes symptoms or hospitalization due to diabetic ketoacidosis, and the second children usually had abnormal glycemia based on a home monitoring. Most of our respondents were women, and more than half of the parents had higher education. Most of them didn't have any knowledge about the type 1 diabetes before their first child diagnosis. When we compare the emotions between the first and the second diagnosis, we can see that at the first diagnosis, parents felt mostly shock, sadness, and fear of the unknown. And in the second diagnosis, the dominant emotions were grief, anger, and sadness. These emotions were statistically significant. As we can see here, most parents were aware about the risk of type 1 diabetes developing in their second child, but still 27.7% didn't have any knowledge about it. Regarding the possible diagnosis of their second child, most parents were concerned about their second child's health deterioration. Unfortunately, only 45.5% of parents that were surveyed had knowledge about the screening. Still, more than half of them didn't have any knowledge about it, and only 30% of people who had knowledge about the screening decided to take part in it. Mostly in Inodia study, which was available back then. Also, as we can see here, parents didn't notice any emotional relief after screening. Also, we wanted to see if parents' awareness about the risk of developing type 1 diabetes in sibling will influence their decision of taking part in any preventive test, so performing any preventive tests such as glycated hemoglobin levels or diabetic antibody testing or glycemic measurements in their children. And as we can see here, 68.1% of parents decided to undertake those preventive measures, probably aiding early diagnosis. Also, parents reported that the first diagnosis was both caused them both greater emotional difficulty, and also providing care for their children was much difficult during the first diagnosis. And to sum up my presentation, during the first diagnosis, the first diagnosed child had better clinical results and showed a better clinical presentation at the onset. Most families were aware about the risk of developing the type 1 diabetes in the other child, and they decided to do some preventive testing in their second children. Though the second diagnosis was emotionally easier to parents, it still caused them a lot of distress. That's why it is important to support parents psychologically during first and the second diagnosis. And also, it's really important to educate parents better about the possible options of screening and the benefits of it, to encourage them to take part in the screening. And that's everything from me. Thank you, and I will gladly answer any questions.
Okay, congratulations for your work. Could you tell me if the parents of, I don't know, someone in the family has diabetes, not only type 1, but type 2?
In our
what is family history of those patients, of those parents?
So in our study, we conclude only families who had 2 or more. In our study, only 2 childs were affected with type 1 diabetes. We only included families with type 1 diabetes history. We also wanted to check if parents who take part in our study had knowledge about the diabetes. We also asked in diabetes in general, mostly the type 1 of diabetes, but we in our survey, in our questionnaire, asked about some diabetes in general, but the majority of parents didn't have any knowledge about any type of.
So it suggests that there is no. This is like question. Mostly, I am curious about like it's this children with diabetes type 1. It's the first in the family.
Yeah, mostly, yeah.
Okay. And that's it. Like from me, like congratulations.
No more questions. So thank you for your work. And now, please, Patrick Stabrava. He will present the paper, The Role of Intraoperative Neuromonitoring in the Surgical Treatment of Spinal Lipomas in Pediatric Patients.
Good morning, everyone. I'm Patrick Stabrava, and I show you the role of intraoperative neuromonitoring in the surgical treatment of spinal lipomas in pediatric patients under the supervision of Dr. Ryszard Sordul. Spinal lipomas are amongst the most common malformation in pediatric neurosurgery. Diagnosis is often based on visible lipoma, or birthmarks. Spinal lipomas are formed during neurulation. It's a process of forming a neural tube. We have primary and secondary neurulation. Spinal lipomas are mostly formed during primary neurulation due to mesodermal invasion to ectoderm tissue. We use Morota's classifications, a classification that have 4 types of lipoma that we can distinguish using MRI scans. As we can see, we have from type 1 to type 4, and the treatment is always based on the Morota's classification. From type 1, when we use radical resection, type 2 and 3, when it depends, mostly it's only untethering, and to type 4, when it's mostly section of the film terminale. What is intraoperative neuromonitoring? Is to prevent neural distinction. We have 2 types. Continuous monitoring of neurous system function. As motor evoked potential, we use it the most. Somatosensory evoked potential is not really useful. Bulbocavernosus reflex and techniques for mapping neural structures. Live is triggered electromyography. So the aim of our study was assessment of the role of neuromonitoring in the treatment of spinal canal lipomas at the Department of Pediatric Neurosurgery, Medical University of Silesia in Katowice. With a retrospective analysis of medical records of children treated for spinal lipomas at the Department of Pediatric Neurosurgery. Study period was from 2012 to 2022. We use most of the patients during this time. And the following evaluated clinical presentation, imaging findings, presence and modality of neuromonitoring, and treatment outcomes. Follow-up was presented from pediatric neurosurgery outpatient clinic. Our study populated with 39 patients, 24 girls and 15 boys, and the average age of patient was 2.9 years. 18 patients was without neuromonitoring and 21 patients was with monitoring. As we can see on the chart, the value of neuromonitoring increased during the years, as well as surgeons learned to be better of using neuromonitoring. Clinical manifestation before surgery is mostly birthmarks, lower limbs paresthesis, neurogenic bladder, and syringomelia. And surgical procedure during intraoperative monitoring and without is the difference is mostly on anesthesia when we can't use inhalation agents or muscle relaxant. And of course, during neuromonitoring, we had detachment of this lipoma from the placode under neuromonitoring guidance. The impact of intraoperative monitoring, we can see that without IOM, there were more cases with undethering of the spinal cord, and with IOM we had more lipoma resection as the surgeons were more confident with the surgery. As an early outcomes, there wasn't much difference between the groups, but in the postoperative complication, there was one case of worsening lower limb paresthesis in non-intraoperative neuromonitoring that could be theoretically prevented with monitoring. And with IOM, we had sphincter dysfunction that couldn't be prepared because surgeons don't use bulbocavernosus reflex to children to age 5 because we can't. And Follow-up represents 4.4 years, without IOM is 6.39 years, and with IOM is 2.7 years. Follow-up shows that IOM has more improved patients, even though the follow-up were more shorter. And interestingly, we had more reoperation in IOM group, even though follow-up was more shorter. We had slightly more reoperation in IOM group. To conclude, in the study population, intraoperative neuromonitoring reduces the incidence of complete spinal cord dithering, increases the rate of complete resection of lipoma from the spinal canal. That has no significant impact on the occurrence of early neurological complication, and may have a positive effect on long-term clinical outcome. Thank you very much.
Okay, thank you for your presentation. It's more surgery case than pediatric, in my opinion, but it's good for us today. I have a few questions. First, maybe you mentioned it, but I didn't catch up it. So why only like 18 of the patient have operation with neuromonitoring? Why not all?
Yes, because
18. Sorry.
Yeah, it wasn't on the procedure of intramonitoring started like in 2016, not before. Surgeons didn't use it because they didn't have data that it's better and wasn't prepared for it.
Okay.
And wasn't technically. They couldn't do it technically.
Okay,
really.
so it's
there wasn't
problem.
Yeah.
Okay, understand now. Thank you. The second question is: do you know what kind of other surgeries are using neuromonitoring?
With thyroid.
Yeah, very good,
yeah,
very good.
To the nerve of the
recurrent nerve.
The thyroid, yeah.
Recurrent nerve. That's very good. And we are using neuromonitoring in, I think, Hirschsprung disease from the neurons of structure. That like this is premium question, so but it's good for you. And the other is also maybe premium question, or maybe you mentioned about it. Sorry. Do you know how many children or anyone have from this patient got neurotic bladder?
After the operation, there was no worsening of neuronic
No,
bladder.
after, but those children were born with this kind of spinal lipomas, and because of that, because of like this spinal affect, defect, did anyone have neurotic bladder?
Yeah, it's about 15 to 20% of children had it. Yeah.
Okay, thank you. Thank you.
Thank you very much. Thank you.
Okay. And now participants will be with us online. Michalina Figiel, do you hear us? Okay, I see you. Hello. Can you show us your presentation on your own? I'm sorry, I didn't hear you. Can you say something? Still nothing? Still nothing, I'm sorry. No? I see that you try to tell us something, but we didn't hear you. Okay, so maybe next presentation.
Proszę spróbować udostępnić cały ekran.
Widzimy, ale nie słyszymy.
I teraz na pełny ekran proszę dać. Tam masz przycisk po lewej stronie od początku.
Maybe at the end of the session we will try again, okay? So now please Weronika Curyło. She will present her paper about pediatric family hypercholesterolemia in Silesia.
So, good morning, ladies and gentlemen. My name is Weronika Curyło, and today I have the pleasure of speaking to you about a condition which plays a critical role in cardiovascular prevention as well as everyday clinical practice, familial hypercholesterolemia. The tutors of my work are MD, PhD Kamila Szalika, MD Agnieszka Pietrusik, and Professor Aneta Gawlik-Starzyk. Familial hypercholesterolemia. So we may already get an idea about what this disease is about. Probably high cholesterol levels as well as familial inheritance, right? Correct. It has some correlation to mutations of the ApoB, LDLR, and PCSK9 genes. And you may think, oh, another genetic disorder. I will probably only hear it here at this conference and maybe at my genetics exam. But what if I told you that if you have a friend's Facebook list, which is at least 300 friends on Facebook, then at least one of those friends has this mutation? Because familial hypercholesterolemia is no joke, and it's the most common inherited life-threatening human disorder. 1 in 300 patients suffers from it. So there is a need of better screening and finding those patients. And actually, I have great news. Fresh news. It's just a few days old. Right now, we are in the process of incorporating a system in which we have daily checkups of 6-year-olds, and then we measure the total cholesterol levels in the blood serum. But what about the older patients, their siblings, their family? Cascade screening is the answer. Like here, this family of 5, we had a positive test of one of the patients, and we should immediately think of testing another family members, their siblings, their parents. So what is the cause of all this? Mutations in those genes. Why? Because normally the low-density lipoprotein bind to a ligand. It's called apolipoprotein B, and the LDLR receptor, which then leads to metabolism of lipids in the hepatocytes. But when an FIH mutation occurs, LDLR mutation as well as ApoB dysfunction leads to not binding those LDL and leads to, in consequence, a higher total cholesterol level in the blood serum. The PCSK9 mutation is a gain-of-function mutation in where the protein PCSK9 hides the LDLR receptor and it cannot bind the LDL and therefore it cannot be metabolized in the hepatocytes. The symptoms that you should always pay attention to when thinking about familial hypercholesterolemia is manifestation of deposits in the lipids in the cornea, for example, and it's called the corneal ulcus, and it occurs like a grayish circle around the iris. And also xanthomas, which can occur in the palms of your hands, around the eyes, and also in the Achilles tendons. But you have to remember, here are some photos for you to remember, and you have to remember that those symptoms aren't that frequent in children. And the first and foremost clinical symptom is high cholesterol level. What should we do next? So we have a great tool available open access on the internet. It's called the Simon-Brew criteria. You can open it up right now on your phone if you would like to. I screenshotted it for you. And as you can see, we have several data in those criteria, for example, age, total cholesterol, and etc., so on. And I've put only the positive symptoms of FH, and as we can see, there is a definite familial hypercholesterolemia diagnosis. So the aim of the study was to assess the genetic background and familial burden of hypercholesterolemia in pediatric population in Silesia. And to do this, I analyzed medical records from children with history of hypercholesterolemia, then tested them genetically, and finally used Statistica for statistical analysis. And the results were that 60% of the whole study group had no mutations whatsoever, but 40% had some kind of mutation which led to the disturbed lipid metabolism. And please remember this number for the next slides, 40%. The gender structure was mostly girls. By looking at the gender structure, the girls were the majority, and the LDLR mutation was the most frequent one, and the second most frequent one was ApoB, both in girls and boys. By looking at the age of the patients, I differentiated them in two subgroups using the Broom criteria, over 16 years old and under 16 years old. Under 16 were the vast majority, and as we can see, the minimum age was only 6 months, just a baby, and then the oldest patient was at least, not at least, but just 1 month left till adulthood. And here's the interesting part. I told you previously to remember about the 40%. 40% had a mutation, but only 20.8% of the whole study group using the Broom criteria had a positive definite FH diagnosis. 14.6% had a possible FH diagnosis, and there is, if you calculate everything correctly, 4% gap where there is an unlikely FH diagnosis, but they had a mutation. So this leaves me wondering, that we had some patients, 2 girls to be exact, with an LDLR mutation, but an unlikely FH diagnosis. There were some patients who had no mutation of the genes that we associate with familial hypercholesterolemia, but they still had a possible FH diagnosis. 2 of them marked in pink, as you can see. This is no coincidence, those were 2 sisters. And we also had a few genes that are associated with the disturbance of lipid metabolism, but they are not in the classic definition of FH. ABCG5 and ApoE. ApoE is mostly associated with Alzheimer's disease, right? So aspects worth keeping in the future, for future research. We have some patients without diagnosis, although they have a family history of cardiovascular diseases and early cardiovascular incidents. They have high cholesterol levels, but they are still undiagnosed, so there is a need of better diagnostic tools. We also have the genes that are associated with lipid metabolism and its disturbance, but they are not included in the classic FH definition, although their mutation leads to higher cholesterol levels, so maybe there is some room for change. I created a take-home message as a summary of the whole lecture for you to remember all of the essentials. So first and foremost, the most common inherited life-threatening human disorder is familial hypercholesterolemia. It occurs in 1 in 300 patients. You should use the Broom criteria, which is free, open access in the internet, but it's not perfect, and you should always remember that as well. We already know some of the mutations that cause familial hypercholesterolemia, but you should always think about the others as well, ABCG5, ApoE. And I think that's all from me. Thank you very much. I will gladly answer your questions. My work tutor is here with me as well online. Thank you very much.
Thank you for your presentation. You have really lovely presentation. Like Dr. Kubik is agreed with me, but the question is, and you mentioned that Broom criteria are not perfect, like nothing is perfect, like it's written on a box and on the internet and those labels, criteria, but here come the patient with it and nothing, it's like close to the criteria, like I mean that every patient, every case is different. So there is not such a thing like perfect criteria, but it's close enough.
Of course,
this is my comments. This is not like.
There is actually right now there is an ongoing discussion about those criteria because it's not perfect, and we're going to perfect it in some years.
Good for you. Good for you.
Not we exactly. Maybe I mean I hope we will contribute, but not we. The Dutch and Slovenia is the leading countries in this case.
Good for them. But my question is. Maybe I forgot. No, is those group of patients are on some medication?
Yes, they are. They take statins as a first choice drug, and then the older ones they have ezetimibe, and we also give them omega-3 acids.
And how you tested those patients about? Treating with for example, statins, yes, because we know statins have some negative. They could negative have implements on the body. So, how you control those patients of those medicine?
So actually there is an ongoing discussion which statins should we use according to the mutation that has occurred in the patient, and there are studies conducted right now about this, but primarily the first choice drug in every patient are statins, and then we just look in the symptoms of the side effects of those drugs, and if they are older then we can also think of giving ezetimibe if there is still a high cholesterol level.
Okay, I understand, but how, not you, but how doctors, how doctors control those patients? Like, did they take some tests, blood test, like
for high cholesterol?
No, from
side effects.
Side effects, but not only side effects. Like how you control those children with those types of complication or this type of disease.
Well, they have daily checkups once a year, at least, and they are just looking for the symptoms of the possible side effects if they occurred in the patients.
And what include the checkup?
Physical exam mostly, also asking the parents if they have noticed anything, any change in their children. Just a basic history taking exam.
And a blood test?
Blood test as well, yes,
and
of course.
You know the
lipids, the total cholesterol, the LDL, HDL, 3 glycerides, on daily checkups, what else? Glucose level as well, of course. Fasting glycemia.
And hormones? Any hormones?
Only at the first checkup.
Okay.
Thyroid, globulin, and T3.
Yes.
I think that's.
I think that's.
Yeah.
Okay. Okay. So thank you very much.
Thank you very much.
I have another question from our doctor online. I will ask. Great presentation, congrats, about screening, and that you've mentioned. It is screening going to take place in the whole country, and when does it start? Do you have any information about the cost of such screening?
Of course, it's actually a big success of our Silesian University, of the Zabrze department. It's their idea, and the government is involving daily checkups of 6-year-olds in every school. Every school will conduct this test from finger tests, although it should be taken from the vein, but for screening it's enough. And it will start in a few days, I think. Just right now, it has been already in the news. That's why I put up the slide about the breaking news part. Thank you. Thank you very much.
Congrats. And now the next presenter, Joanna Jacuńska. Do you hear us? She will answer the question, which test is the best, the early diagnosis of secondary hyperpatriotism in children with CKD.
Hi, can you hear me?
Yes, of course. Can you share us your presentation?
Good. Yes, sure.
you need to share us your
Can you see
screen.
that?
No, not yet. You need to share your screen.
Understand.
Oh.
Is it working now?
Yes, it's work, but we're still
You can see
waiting
it.
for your presentation. Oh, okay. I can see. Take this to
You
the
can see
whole-
the first slide.
Yes, but you need to... okay, yes, now it's good. You can start.
It's okay? Like, it's moving?
Yes, it's moving. You can start.
Good.
You have 7
Great.
minutes.
Great. Okay. Okay, so good morning. My name is Jan Majaczyński, and I'm pleased to present our research on the early diagnosis of secondary hyperparathyroidism in children with chronic kidney disease. This work was supervised by Professor Kinga Musiał at the Department of Pediatrics Nephrology in Wrocław Medical University. CKD is defined as a kidney damage or decreased kidney function lasting at least 3 months. It includes a GFR below 60, structural kidney abnormalities or urinary abnormalities such as persistent albuminuria, even in patients with normal or elevated GFR. Our study aimed to assess calcium phosphate balance in children with CKD, disturbances of calcium phosphate metabolism in the course of CKD MDB, which is chronic kidney disease, mineral bone disorder, are presenting pediatric CKD, focusing on differences by age group and CKD stage. We included 100 children newly diagnosed between 2014 and 2024, dividing them into infants and older children from 2 to 18 years old, and categorized them by CKD stage from 1 to 5. We analyzed PTH, phosphate, calcium, and vitamin D levels. However, please note that all graphics analyses shown in this presentation refer exclusively to children aged 2 to 18 years old. This chart shows a clear upward trend in PTH levels with advancing CKD stage. The rise in parathyroid hormone reflects a compensatory mechanism to maintain calcium phosphate homeostasis as a kidney function declines. In CKD, reduced phosphate excretion and impaired activation of vitamin D lead to phosphate retention and hypocalcemia, both of which stimulate PTH secretion. Elevated PTH promotes bone resorption to normalize serum calcium, but over time leads to renal osteodystrophy. In our data, the highest PTH levels were observed in stage 4 and 5, consistent with secondary hyperparathyroidism. These graphs illustrated a progressive increase in serum phosphate with worsening CKD stage. The kidneys are primarily responsible for phosphate excretion. In CKD, this function declines, resulting in hypophosphatemia. High phosphate contributes to vascular calcification and bone mineral disorders. In children, phosphate levels must always be interpreted using age-specific references range, as physiologically, higher values are normal in early childhood due to rapid skeletal growth. Phosphate levels correlate with CKD stage, confirming that phosphate is a reliable early marker of mineral dysregulations. These results emphasize the need for dietary phosphate management and early use of phosphate binders in advanced CKD. However, calcium levels remains relatively stable across CKD stages in our study. This is due to multiple compensatory mechanisms. Hypocalcemia tends to be a transient and mild, as the body prioritizes maintaining serum calcium at the expense of skeletal stores. It's important to evaluate calcium in conjunction with PTH and phosphate, not only in the isolation. You cannot only classify by higher calcium. And the last, vitamin D levels were consistently low across all CKD stages, without a clear relationship to disease severity. This suggests that vitamin D deficiency in children with CKD is multifactorial. It can be also the reason reduced renal conversion, low sun exposure, and poor nutritional intake. Since low vitamin D increased secondarily hyperparathyroidism and impairs bone health, routine screening and supplementation are critical even in early stage CKD. And here are some line plots I want to show you. The first line plots clearly show that PTH and phosphate levels increase progressively with advancing CKD stage. This confirms their usefulness as early and stage-sensitive biomarkers of CKD, MDB, and secondary hyperparathyroidism. Second, calcium levels remain relatively constant across stages. This suggests that calcium homeostasis is maintained at least temporarily through compensatory mechanisms such as increased PTH secretion and supplementation. However, this also means that calcium alone is not a reliable marker, as I said earlier. Third, the constantly low vitamin D levels show in both box plots and line plots highly and generalized deficiency not directly linked to CKD stage. This likely reflects both renal dysfunction and broader public health trends, and underscores the need to routine screening. And the last diagram that I want to show you, the top left plot, PTH versus phosphate, we can observe a positive correlation. Higher phosphate level are generally associated with higher PTH concentration. This reflects the classical physiopathology of secondary hyperparathyroidism, where phosphate retention stimulates PTH secretion. Otherwise, top right plot, PTH versus calcium. Here the relationship is less clear. There is a slight negative trend, as expected, because rising PTH should mobilize calcium from bones, but the variability is high. This suggests that calcium is more tightly regulated and influenced by multiple factors such as supplementation and albumin level. And bottom plot, PTH versus vitamin D. In this case, we can see a mild inverse relationship. Lower vitamin D levels tend to be associated with higher PTH. This supports the well-known role of vitamin D in suppressing PTH synthesis. However, the spread of points also show that vitamin D deficiency is common across all PTH levels. And to summarize, PTH and phosphate are the most reliable markers of CKD stage at diagnosis in children. Calcium and vitamin D, or less specifically, all the vitamin D deficiency is highly prevalent and should be addressed regardless of the CKD severity. Interpretation of phosphate in children must always be considered by age. Finally, regular biochemical monitoring is the key for early identification and management of secondary hyperparathyroidism and CKD MDB. Thank you so much.
Congratulations on your presentation. Thank you. And now it's time to discussion. Our committee, do you have any questions? Maybe committee online? Okay, so maybe I will ask, what is your contributions to the work?
Actually, I started taking care in our Student Scientific Association about chronic kidney diseases in 2023. I analyzed all the patients, so basically all the graphs are mine. I do it by using Statistica program. Our professor early gave us her code to the case medis and asked the IT in our hospital to give us the patient, but we have all hospitalization of the patient, so I needed to go through all the data, all the patient history, collect them, and then analyze them. So first we had like 300 patients, and then I cut it to 100 because only 100 patients had 4 PTH, phosphate, calcium, and vitamin D with their when they first came to our clinic.
Okay, so thank you for your answer. And Dr. Kubik, do you have any questions?
Yeah, I wanted to ask you, do you have any suspicion why calcium concentration and vitamin D levels, they are not as good markers as hormones, for example?
I think it also depends by our diet and the climate. For example, we cannot compare in like the data that are general around the world, and for example there are different types of there are different levels of vitamin D that we can absorb in Poland comparing, for example, to Spain because of the lack of sun. And about the diet, for example, if you eat a lot of dairy products, you have more likely to have a higher level of calcium instead of people that are lack of dairy diet. That's what I think, but I'm not 100% sure.
Okay, so thank you for your presentation and being with us. And now it's time for Monika Roszkowska. She will present the paper about the way from heart to the liver, hepatic complications of fontan circulation.
Good morning, my name is Monika Roszkowska, and then it's my pleasure to present our study entitled The Way from Heart to the Liver, Hepatic Complications of Fontan Circulation, focus on Fontan-associated liver disease, or FALT. Fontan-associated liver disease is an acquired chronic liver condition observed in patients who have undergone the Fontan procedure. While this surgery significantly improves survival in children with single ventricle congenital heart disease, it is associated with hepatic complications such as fibrosis to portal hypertension and cirrhosis that may manifest around 10 years after the procedure. The Fontan operation restores normal circulation in the presence of unventricular heart. The procedure is the final stage of a multi-step heart reconstruction. Initially, the pulmonary trunk is connected to the functional ventricle and the aorta, diverting blood from the lungs. Lung circulation is maintained by removing the atrial septum and connecting the right subclavian artery to the pulmonary artery. In the final Fontan stage, the inferior vena cava is also connected to the pulmonary circulation, and the subclavian pulmonary connection is closed. The most important thing for you to understand is that the venous system is completely separated from the heart after the procedure. The pathophysiology of FALT includes high central venous pressure, chronic venous congestion leading to sinusoidal dilation and hepatocellular atrophy, reduced cardiac output, contributing to hepatocyte hypoxia, chronic low-grade inflammation, and also lymphatic dysfunction. These processes results in hepatic fibrosis and eventually cirrhosis in some patients. The proposed pathophysiological mechanisms have not yet been definitively confirmed. So, which came first, the chicken or the egg? Researchers continue to debate whether hepatic dysfunction worsens cardiac performance or vice versa. This highlights its crucial need for a lot more studies on FALT to better understand of its symptoms, progression, causality, and dynamic. FALT is often clinically silent for many years, making early detection challenging. When do the symptoms arise? They may include hepatomegaly, ascites, peripheral edema, coagulopathy, jaundice, and importantly, the annual risk of hepatocellular carcinoma in this patient population can reach up to 5%. Our study included 24 patients aged 4 to 17 years with a male predominance. We collected data on the type of cardiac defect, laboratory values, clinical findings, and imaging results to assess hepatic involvement. Laboratory results revealed elevated gamma-glutamate transferase levels in 91.7% of patients, abnormal AST and ALT in approximately 20 to 25%, no elevation in alpha-fetoprotein in any case, and this finding suggests a subclinical hepatic injury in studied group. Let's take a closer look at the cardiological characteristic. We observed that 10 patients, or 41.7%, were diagnosed with hypoplastic left heart syndrome, while 12 patients, making up to 50, had tricuspid atresia. Additionally, the average pulmonary pressure recorded was 20.5 millimeters of mercury. Parameters measured during the cardiac catheterization revealed that the pulmonary pressure and PVR index values were optimal. Also, echocardiographic assessment revealed the good function of the single ventricle. Functional cardiac assessment highlights some key concerns. Although the mean ejection fraction was 62, indicating generally preserved systolic function, some of children had values as low as 45%, suggesting early signs of ventricle dysfunction in a subset. The fractional area change, another measure of ventricle performance, show a broader spread ranging from just 21% to 51%, hinting at the compromised myocardial contractility in some patients. NT-proBNP acts as a marker for heart failure. However, even though the average in our patients show an increase, it is difficult to find a pathology here in the absence of symptoms in heart that has undergone such an extensive anatomical changes. Imaging studies, including elastography, demonstrated advanced fibrosis in the majority of patients. 41.7% were classified as F3, which is a severe fibrosis, 50% as F4, which is cirrhosis, with a mean liver stiffness of 11.44. This data suggests that the majority of children with FALT after the operation already have advanced liver damage. Here we can see the ultrasonographic findings in our patient group and also the gastroscopy findings. Out of 24 patients, 60 showed abnormalities, which correspond to 67%. The most common finding were liver of heterogeneous echogenicity and outline image of prevascular fibrosis tissue, each presented in 50% of cases. Splenomegaly was observed in 25% patients, while hepatomegaly appeared in nearly 17% of the patients. Least frequent was cirrhosis, seen in only one patient, accounting for 4.2%. Also, 3 out of 24 children had esophageal varices as a sign of portal hypertension. This result suggests in high incidence of liver-related abnormalities in our cohort. This graph showed the Pearson correlation calculated for AST and age of surgery in months. This is moderate positive correlation with statistically significant p-value. This suggests that AST tends to increase with age at the operation. In conclusion, the Fountain procedure extends life expectancy in patients with single ventricle physiology. However, it places them at significant risk for liver diseases, which may remain silent for many years. Our patients are at the beginning of a journey that unfortunately may lead to deterioration of their condition in the near future. Routine hepatic monitoring using laboratory tests and imaging should become a routine standard component of follow-up care. Multidisciplinary collaboration involving both hepatologists and cardiologists is essential for early diagnosis and prevention of long-term complications. Thank you very much for your attention. I'll be honored to answer some of your questions and just enjoy the conversation. Thank you very much.
Thank you for your presentation. It's a very interesting topic.
Thank you very much.
But it's docent język, so it's
yes.
Everything. I'm sorry for the audience, but the docent język is my personal pediatric hero, so I'm not objective with it. Okay, but to the question, yes. I have a question similar to question before, presentation before. So, what would you do with those patients? Like it's heart cardio surgery procedure once, but about the liver, how often should they be examined? What types of laboratory and how often should take the laboratory test? What is they have to eat, like their diet?
Yeah, so starting with the diet, they have a protein loss. So their diet should consist of a lot more the protein income. Mm-hmm. So the all of the children, they have very low BMIs. So after the birth, they also need to eat a lot more protein than usual children.
But protein, I'm sorry, protein you mean with milk, with some food, or like some specialist treatment like Nutrini or something like that?
Yes, special treatment also. Mm-hmm. It depends on all of the rest of the hepatic parameters. Mm-hmm. If the hepatic parameters worsen, so they need like the specific diet. Mm-hmm. Here in our clinic, they are usually often once in 3 months or 6 months. Also, it depends on the hepatic parameters. And we also always check the AST, ALT, GGT. They have elastographic also. And sometimes the endoscopy.
Endoscopy,
yes, because they have like a higher risk for the esophageal varices because of the high pressure. That's why they also have the gastroscopy.
So gastroscopy and like some test like USG or
yes, of course, USG of the abdomen, of course, yes, also.
And others, tomography or MRI? No, it's not included.
No. Okay. Elastography, USG, sometimes the endoscopy of the esophagus. And basic lab tests, such as I mentioned before.
Okay. Thank you very much.
Thank you.
We have one question for our jury online. Are there any possibilities to avoid series that are non-pharmacological?
Could you please repeat again? I can read. Thank you for this question. As far as I know, with the as far as this disease happened or worsened with the age of the children, all of them probably will have the cirrhosis. So it's just a matter of time, unfortunately. So I don't think so. Is there any? Thank you very much.
Okay, and now we'll try again with 11th work. Michalina Figel, are you there?
Hi, hello.
Hello.
I hope now you could hear me when I share my presentation.
Yes, sure, we can hear you, so you can start, show your presentation.
Now you can hear me?
Yes, I can hear you, and I see your presentation. When you're ready, just start. You have 7 minutes for presentation.
Okay, so ladies and gentlemen, dear jury, the topic of my presentation is facial injuries from the animal bites in the pediatric population. This work is based on the retrospective study and the literature review. And starting with the epidemiology, the face accounts for 10% of all bites in the pediatric population, of which as many as 70% affect children under the age of 10. The most common target of animal attacks in adults and older children is dominant hand of the upper limb. And studies show that the most common aggressors are domestic animals, with dogs responsible for 70 to 90% of cases. And this distribution may result from the fact that the dogs are the most popular pets worldwide, and in Poland in 2020, nearly half of residents owned at least one dog. The most common complication after a bite is infection. Wound contamination can lead to localized infection or spread systemically. Other severe complications of bites may include neurovascular injuries, fractures, damage to the visual apparatus, or even death. Our retrospective study included patients treated at a regional specialized children's hospital in Olsztyn over a past of 5 years. The target population consists of children up to 18 years old hospitalized for facial injuries caused by animal bites. The inclusion criteria for the study was based on the international classification of diseases. And initially, patients with head injuries were selected, then children with superficial injuries to the scalp were excluded, and from the remaining group, cases involving animal bites to the face were isolated, resulting in a final study group of 25 patients. Our study found that there was majority of bites were caused by dogs. Literature is consistent with our finding, indicates that the most children are bitten at home. Bites occur more often in boys, although we did not find any statistically significant correlation between the gender and the injury frequencies. Other studies highlight this difference. However, we found that the boys suffer injuries at an earlier age, which was statistically significant. As can be seen, most patients were preschool-age children. According to the literature, the highest injury rate is among children under the age of 5. And animal bites typically cause soft tissue damage to the face. Fracture associated with bites are rare, and the literature reporting fractures rate of 1 to 3%. In our study, the risk of fracture was low, with odds ratio less than 1. An interesting finding included post-traumatic brain edema in 2 patients and pericerebral hematoma in 1.
Although these were not statistically significant, we emphasize the potential risk of such complications. Some patients presented symptoms such as somnolence, loss of consciousness, headaches, vomiting, and nose bleeding. If traumatic brain injury is suspected, radiological imaging should be performed. In our group, 2 CT scans were performed showing brain edema and in one case skull fracture and pericerebral hematoma. And all patients received multidisciplinary medical care totaling 27 consultations across various specialties. And the key steps in management include surgical treatment with proper wound debridement and the prophylaxis for infection, tetanus, and rabies. And according to the literature, the choice of the anesthesia methods depends on the type of wounds, its location, and child's age. In our study, all surgical procedures under local anesthesia were performed in girls, likely due to milder injury and older age. And to prevent infection, antibiotic therapy was administered to 24 patients. And the most commonly selected antibiotics were amoxicillin with clavulanic acid and cefuroxime. In every case, immunization status against rabies and tetanus was assessed. Ultimately, 19 patients received the rabies vaccine. And the most common post-operative complication is hypertrophic scarring, which causes aesthetic and functional problems in children. To prevent cosmetic defects, post-operative laser therapy is used. In our review, 6 patients underwent laser therapy. And we could ask, why do animals attack children? It stems from the fact that the children have less experience in interacting with animals, are more likely to provoke them, and cannot recognize dangerous animal behaviors. And according to literature, behavioral disorders are also risk factors for injuries. A child's face is the main target of the attacking animal. This is likely due to the child's short stature and the relatively larger size of their head to the rest of the body, making the face more accessible to the animals. And in summary, facial animal bites are most often caused by animals known to the child, occur mainly at home, and more frequently affect younger children. Despite a wide range of severity, nearly all cases require antibiotic prophylaxis, surgical intervention, and rabies prophylaxis. And the studies emphasize the importance of early intervention to prevent infection, treat wounds, and minimize long-term physical and psychological complications. And thank you for your attention.
Thank you for your presentation. Dear jury, do you have any questions?
Thank you for your presentation. I was smiling because of rooster, and it's unexpected for me to bite by the rooster, poor boy. But could you tell me what was the treatment for the bites besides surgical treatment? Is there any other treatment for it, added to surgical treatment, of course?
Prophylaxis for infection by antibiotics and prophylacsis for tetanus and rabies.
Yeah, the tetanus. I see that, but it was systemic antibiotics or in ointment. Do you know this?
No, unfortunately, no.
Okay. I am curious because we in our ER, on our surgical ER, we're going those patients only systemic antibiotics, and not some Bactroban or other ointments. So I was interested what you're doing on Warmian Mazury, And I have one other question. You mentioned about 2 cases of head injury, and one of them was hematoma, yes?
Yeah.
So this patient was he admitted to, I don't know, neurosurgery? Did he had an operation? Did he live?
Yeah, he lived and he was admitted into neurosurgical department and had an operation. Yeah.
Okay. Okay. Thank you.
Thank you.
Okay. I think we have no more questions, so thank you for your presentation. And yeah, I think all the submitted papers have been presented. We will congratulate of the presenting authors and participants on the Neonatology and Pediatric Sessions SIMC 2025. And at this point, I would like to ask the president of the jury, Dr. Marianna Łoskot, to sum up the session, to say something for our participants.
To i tak nie ma różnicy, ale trudno. Okay, so congratulations to you all. You are few left on the audience, so congrats to you. I really like pediatric session because the level of the presentation is really high, and it's very interesting cases. Like most of the cases was interesting to me, so I hope you become a great pediatrician or neurosurgeon or whatever you want, and you continue this work on your PhD level. I think you should all go to become like doctor. So good luck to you, and I hope to see you at this. All right?
Yes, all right. I tell about it.
Okay, so that's all for me. I will speak Polish right now. Ja mam tylko drobną uwagę dla Państwa. Komisja umie czytać. To bądźcie tego świadomi, więc tak dla uproszczenia dla Was, nie musicie zawsze czytać, że jesteście z koła naukowego, że Waszym tutorem pracy jest 6 profesorów i tak dalej. Jakby to możecie to zostawić, iść dalej. Tak samo nie zawsze musicie czytać wszystkie procenty, bo to na przykład to jest takie trochę Makarena później. Jak czytacie 68,76%, to też potrafimy czytać, a tylko przeczytajcie to, co najważniejsze. To taka drobna uwaga, a myślę, że wiele Wam ułatwia i będzie łatwiej też zrozumieć, bo czasem tych informacji było bardzo dużo na slajdach. No to tak tylko tyle chciałam powiedzieć.
Dziękuję. Dziękujemy bardzo. Now I need to talk in English. So, Dr. Kubik, thank you for being with us. Dr. Mucha and Dr. Ciepły, thank you for being with us online. And I would like to thank all the participants for your time, for your work, and being here with us. I want to invite you to the decoration and closing ceremony of the SIMC 2025, which will be held here in this hall today at 5 p.m. And the dinner just started, so dear participants, I will invite you to the lobby. And what more? Yes, and I would like to invite you to today's end of conference party, or the details are on the poster behind me. So thank you for taking part in this session. I wish you all the best, and I hope you see you soon. Thank you.